very important topic in orthopedic treatment. So first of all, we talk in orthopedics about orthopedic treatment and orthopedic surgical treatment. Splints and casts are usually used for orthopedic treatment or till surgery. You have to understand that it's an important difference between splints and cast. The splint is a form of immobilization that is not used as a definitive treatment for orthopedic lesions. It's used usually till the It's usually used till the swollen limb is partially disinflamed, and after that we replace it with a cast. Yeah, they play the splints play an important role in the management of lesions, especially in fractures and dislocations. They can be used as a definitive or a provisory treatment till the lesion is treated surgically or replaced with a cast. It offers a good immobilization, but we still have to avoid complications that can result from increased pressure in the limb that it's immobilized. It has to be mounted by someone with experience to have good results. The scope of the presentation is to offer you the information about splints and casts, and offer you information about the most important techniques that you'll have to use to apply them. Necessary equipment, we have cotton bandages, we have the gypsum or the fiber bandages, and hot water. In these images, we have in the upper left image, we have the gypsum bandage, a normal bandage in the center. And in the lower center image, we have fiber, the fiber one type. In the right of the slide, we have modern immobilization techniques, orthotics. In the upper image, we have an orthotic for most probably used for a lesion in the shoulder. In the lower image, we have I think you saw it and you know it, the air cast, used usually for lesions around the ankle. Again, we have the gypsum bandage, the fiber bandage, and the one that are already prefabricated. You can see them in the right upper image. The bandage needed for immobilization can have different sizes, 7 to 8 centimeters for the lower limb, 6 to 7 centimeters for the arm, and 4 to 5 centimeters for the lower arm. The gypsum is a bandage impregnated with gypsum powder. After it takes contact with the water, it starts to harden. We don't have to use it. It's forbidden to use hot water because the gypsum in contact with water gives high temperatures, and we don't have to use hot water. After 3-4 minutes, it hardens, getting to a maximum resistance at 24 hours. Advantages, they are easy to apply, they have a low price, they have a good tolerance by the patient. The porosity of of the gypsum gives the skin the opportunity to breathe through it, and the allergic phenomena are rare. They are used in treatment of fractures. It's a non-invasive measure, a low infection risk. They have a good mechanical quality. We can also model it very good. So this is an important advantage in the treatment of orthopedic lesions. Has these disadvantages, of course, is a discomfort to wear it, because we also have to immobilize the upper joint and the lower joint around the lesion. The thromboembolic risk, we always have to take it into account with all immobilizations. And the radio transparency is not so good, so it could make difficult the radiographic evaluation. As complications, we can lose the reduction of the fracture, uh, stiffness of the joint, especially with the elbow and the knee, the complex regional pain syndrome. It could also be a complication. Skin complications, thromboembolic disease, always taken into account. Nervous complication, as you see in the image, and vascular complications, the compartment syndrome, the most redoubtable complication that may arise from using give some immobilizations, orthopedic immobilizations, they say it. Here we have the Gibson bandage. Of course, we do not use it directly apply on the skin, but here are some examples just for you to see how it works. Advantages: it's cheap, it's easier to apply. Another disadvantage is that when it comes in contact with water, it could break, or it could modify its initial form. So we lose reduction or the position that we wanted for immobilization. The fiber bandages are more resistant, um, but they come with some advantages, but also with disadvantages. Some of the advantages are that it hardens quicker, it's easier to wear, and it's water resistant. As disadvantages, it's expensive and it's hard to apply. And of course, it's not extensible. So the limb immobilized with fiber bandages would not be able to swallow anymore. If the orthotics are prefabricated for different segments of the body, as you can see in the images. Basic principles for immobilization. We always have to immobilize the joint above and below the lesion. We also have to those in the lower images are some lesions that we immobilize them just till the patient goes to the OR. So we always have to consult an orthopedic surgeon when we use some kind of immobilization in the emergency room, in the ER. Always call an orthopedic, because the patient may have open fractures or vascular or nervous lesions. Some other examples of lesions that are immobilized in splints, yeah, not in casts, till the patient arrives in the OR. The technique, as I told you, we do not use the Gibson bandage directly on the skin. We first put the cotton bandage on the skin, at least 2 layers, and 3 to 4 layers at bony proeminences like the head of the fibula, the malleolus, the patella, and the olecranon. Then we apply the gips, the Gibson bandage, and we model it as in the end we will have 3 points of fixation, as you can see in the image in the lower right. Be careful about the alarm signs that could arise after improper immobilization, as nervous symptoms, excessive swollen, and problem with the circulation of the blood. Yeah. Um, just a second. Sorry for that. The preparation, we need to expose the whole limb. We have to wash the limb before applying the immobilization, and we always look for vascular nervous lesions. We have to prevent articular stiffness and loss of function by putting for example, putting the wrist in a functional position. We have to reduce inflammation, asking the patient to raise up her leg, apply some ice in the areas where we do not have a cast, where we have a splint, and administer anti-inflammatory drugs. We always tell the patient to return to the hospital if important symptoms arise, like excessive swollen, excessive pain, neurological symptoms. We always reevaluate them at 48 hours. Pay attention for the 5 Ps: pain, pallor, paresthesia, pulselessness, and paralysis. Those are the most important signs of the compartment syndrome. We evaluate them after 7 days after that. Complications, they appear rarely if the immobilizations are correctly applied. The most frequent complications are minor skin lesions. Always take care about vascular nervous complications if an immobilization is applied too tight. We have to measure the zone and calculate how much material we would need. Never use excessive material for immobilization. We have to apply first the cotton bandages. As I told you earlier, 2 layers are more than sufficient, but 3-4 layers at bony proeminences. After that, we put the Gibson bandage in water, in warm water, not in hot water. We get water out from the bandage. After that, after we put it on, we leave it for 5 to 6 minutes to harden. This is the moment in those 4 to 6 minutes. This is the moment when we modify different positions of the limb. After 24 hours, the immobilization is at its highest capacity when it comes to resistance. So now we'll talk about different types of immobilizations for the upper limb. We have the thoracobrachial immobilization. We use it for scapular fractures, fractures in the higher humerus or diaphyseal humeral fractures. The arm is in 45 to 60 grades of abduction and 30 degrees of anteduction, with the elbow flexed in 90 degrees. The hanging cast, or the Caldwell-Gibson, it's used especially in certain types of diaphyseal humeral fractures. It's a hanging cast because in the region of the elbow, we have some weight, 500 to 1,000 grams, and will distract the fracture in the diaphyseal humerus. Yeah. The principle is to obtain a good functional result to restore the length of the humerus, the rotation, and some decalation if it is. After 5 to 10 days of Caldwell gypsum, we will use an adjustable orthotics. The patient after that it starts to move his arm. The results are in general are good because the humerus, if it heals with an angulation below 5 degrees, 5 to 10 degrees, it's very well tolerated by the patient. Orthopedic immobilizations at the level of the forearm. You always have to take into account that the metacarpophalangeal articulation joint should be free. The thumb should be free as a patient should make a V with his fingers. Yeah, you can see it, the V. You can see it in this image between the first and the second. Okay. The brachio-antebrachial immobilizations are used in the distal humeral fractures, radial head, the capitulum fractures, olecranon fractures after reduction of elbow dislocation, fractures without any uh, movement in the forearm, not without any movement, sorry, fractures without any distances between the fragments in the forearm. Rarely happens, but it could be used. We applied it from the level of the metacarpophalangeal joints till the third, medium third of the arm. So, what kind of fracture do we have here? Can anyone tell me? Hey, are you still with me? Can anyone tell me what fracture we have here in the image?
Fracture on
We have a fracture of the ulna and the radius.
Yeah, that's correct. Localized where? Because, you know, when we describe a fracture, you have to also point out the proper localization. Yeah.
In the proximal extremity of the radius.
In the distal third of the radius and the ulna. Yeah. Proximal is when it comes forward to the body. Yeah. So it's distal for the elbow, referring to the elbow, let's say. Okay, so it's a distal third of ulna and radius fracture. Okay, do we have any displacement in the fracture?
it's small.
It's small, it's a small displacement, but still exists. Yeah. So in the lower images, one of my colleagues, what has he done there in the lower images? Now,
Put a cast.
sorry, I didn't hear that.
Like in the image on the bottom right side, he has a cast on.
Yeah, he has a cast on it. He tried to reduce it and then immobilized the forearm in a cast. Yeah, that's right. But you can see that the reduction, the images post reduction are not quite. Are you satisfied with them? Are you satisfied with the reduction? Sorry.
Not really.
Not really, yeah. This is why I wanted to find out if you're satisfied or not, because usually the forearm fractures do not reduce very well just by traction and orthopedic maneuvers, yeah. In most cases, forearm fractures of both bones are usually treated with open reduction and internal fixation. Yeah. Okay. Mm, I wanted to ask you, the colleague of yours that told me earlier that this is a cast and not a splint. How did you know? Can you tell your colleagues, because it is important?
On the outside of the, I guess on the outside of the arm, you can see like the translucent outline of it.
Okay, you can see the same image on both incidences. Yeah. So if the patient would have a splint, you wouldn't see it also on the profile images. Yeah. You would see it only on the anterior posterior image. It's important because usually those kind of lesions, let's say it's a lesion that was produced by a high energy impact, and the fracture would not be in the distal part of the radius and ulna, and would be in the middle third of the diaphyseal radius and ulna, and produced by a high energy impact. Those are the kind of lesions that if we would use an immobilization like in those images, like a cast that is too tightened, it could arise a compartment syndrome. Yeah, the most frequent areas where the compartment syndrome arises are the forearm and um, the lower leg. Yeah. Okay, let's go forward. Here we have another example of this is a fracture of the only of the distal part of the radius. It's an epiphyseal fracture of the radius that you can see it was reduced and immobilized in an antebrachial cast. This is one of the most common lesions that we treat in the emergency room, in the orthopedic emergency room. I think you've heard about the protocol fractures. Yeah, the immobilization should be done with the wrist in 50 to 30 degrees of flexion and 15 to 30 degrees of ulnar inclination for best reduction of the fracture. The antebrachial palmar cast is used in stable distal epiphysis of the radius fractures, fractures of carpian bones, wrist sprains, tenosynovitis of the extensors or the flexors of the hand. Okay, here is an example of the antebrachial palmar cast, how it is made and how it is applied and how it looks in the end. The long arm posterior splint. It's used usually when you have trauma in the level of the forearm or the level of the elbow. It is used after we reduce an elbow dislocation. Okay, we do not use them in fractures with great displacement. Here it is an image of the long arm posterior splint. In the lower right image is a elbow dislocation, also with a fracture, I think, of the head of the radius. Yeah, and after we reduce it, we use for immobilization we use this splint. Then we'll talk about different type of immobilizations for the lower limb. Here we have the pelvipodal immobilization. It is used rarely in adults. We use it in children. In acetabulum fractures after hip surgery, sometimes hip osteoarthritis. We will skip on it because we do not usually use it. Rarely we use something like this. More commonly used is femoropodal immobilization, femoropodal cast. Disregarding the fracture side, diaphyseal tibial fractures, ankle fractures. This is the immobilization used for definitive treatment. Usually, we do not use a cast. We use a splint, because the lower limb has a tendency to swollen, and we use at first we use a splint for immobilization, and that's, I don't know, 14 days, let's say. After 2 weeks we replace it with a cast. Be careful, the knee has always to be in 5 to 10 degree of flexion, and the leg should be in 90 degrees regarding to the axis of the cuff. Yeah. The immobilization femoral gambier immobilization is used usually for sprains in the knee after reducing patellar dislocation or different inflammations around the knee. And also it can be used for the proximal third of the tibial fractures. Be attention, it usually goes to treating a lesion with this kind of immobilization will probably, I don't know, for 6 weeks, 8 weeks till it heals. It probably would go to stiffness, to the knee stiffness. Here is an example of this femoral gambier cast. It is usually used for, I've told you, for knee sprains, patellar dislocation after reducing them, of course. We do not use it for a long period of time. We do not use it for more than 3 to 4 weeks. The gambieropodal immobilization. We always have to immobilize the ankle in neutral position. The toes should remain free. Here is an example of this kind of immobilization. Gambieropodal cast. Be careful for we have to use a padded, we have to use more cotton bandages at the fibular head to avoid nervous lesions. The ankle should be in neutral position and the toes should be free. This is the graphene immobilization. We use it usually for calcaneus fractures. All the forces that arise in the lower leg will go through the anterior part and middle part of the foot, will go to the calf and to the knee and so on. It will avoid the posterior part of the leg where the calcaneal fracture where it is. The splint. The splint usually is used. It could be used in knee sprains when the knee is too swollen to use a normal cast. Then we use a splint, a femoral-gambier splint or a femoropodal splint. Again, the knee should be in 5 to 20 degrees of flexion. The splint starts like 2 to 3 centimeters below the buttocks, and it goes on till 3 centimeters above the malleolus. The gambieropodal splint, it's used especially in ankle sprains where the ankle is too swollen to use a cast, and then we use a splint and replace it at 7 to 10 days with a cast for definitive treatment for the sprain. So that would be all. Do you have any questions?